Ladies and gentlemen, Christoph, Mr. Chairman, first of all, I'd like to thank for the invitation and the possibility to talk on CRPS. CRPS, what does it stand for? Well, first of all, it does not always look like the same. It does not stay within anatomic boundaries. Pain most often is present, and the etiology has not been elucidated yet. I'd like to draw your attention to the fact that CRPS consists of at least 4 different forms. Most of us are used to this. This is what we in former times called SUDEC. We know of forms with a certain dystonia. There might be color changes of the skin. But if a patient like this shows up in the outpatient clinic, not everybody would think of CRPS. How do we diagnose CRPS nowadays? We speak of the so-called Budapest criteria, which mean there is continuous pain without an proportional incidenting event. Might be trauma, might be operation. We see disturbances sensory, vasomotor, pseudomotor, and trophically. And if there is no other diagnosis that can explain the symptoms, then if the patient reports 3 out of these 4, and the patient shows 2 out of these 4, then we might talk or speak of CRPS 1. In case we can ascribe the situation to a definite nerve damage, then we would call it CRPS 2. There are lots of differential diagnoses to start with: neuropathic pain, vascular diseases. There might be a prolonged postoperative inflammation, arthrofibrosis, as we heard of, myofascial pain in general. So what do we know about CRPS? Well, we know that mostly symptoms do not progress over time, though there might be a spreading within 10% of the patients. It might be very long-lasting, though spontaneous remissions are described. We see women much more often, up to 4 times, and diseases with a connective skin might be a predictive factor. Mental diseases have been questioned for years, but what we do know is that if a patient has CRPS, anxiety and depression are most often diagnosed. How often do we expect CRPS? Well, we know of some operations at the hand, the wrist, the ankle and the foot in which CRPS is described up to 8% of the cases. And talking to this, let's say, knee auditorium, I like to draw your attention on this literature survey where they found more than 350 CRPS patients after arthroscopic knee surgery. Do we know something about prophylaxis? Well, most of all, I guess we'll agree that sufficient analgesia intra- and postoperatively is very important. I would say regional anesthesia, at least additionally, has to be applied. And there are some data that vitamin C as a radical scavenging might be of interest, might be sensible. So what are the hypotheses on CRPS? Well, We think it is a peripheral situation that leads to CRPS. We know of endothelial damage. There are hints for inflammatory reasons. There might be a neurogenic reason, and even immunologic reasons on receptor levels are described. There might be genetic changes, for instance, at the adrenal receptor level. And in many, many cases, we have a problem with the autonomic nervous system. Due to apoptic coupling between the sympathetic chain and the somatic nervous system, we can explain some of the clinical appearances. So what we do have, we have an afferent and an aberrant mechanism. In the end, we find changes in the central nervous system. If we apply functional MRI, we know that the representation of body structures will change with the upcoming of CRPS and might change again with an effective therapy. So this is pathophysiology. Now, what about heart and soul? Well, using MRI, functional MRI, nowadays we know that even social rejection, exclusion, might lead to an activation of regions in the brain similar to those that percept pain and that modulate pain. What I want to say is, I guess there is a final common pathway, different reasons, but the same effect in the end, pain. All that matters to me, all I might lost or all I have lost, might lead to pain. It's not only the, let's say, violence of the physical integrity, it is the not being guaranteed of safety and job, problems in family, lost home, foreign culture, and a reluctance of self-fulfillment. And some of you might see lighten up the pyramid of needs described by Maslow. What does it mean for the patient? Well, to make a little, let's say, philosophical excursus, we would say the individual is alone. That means he has to help himself. But fortunately, the individual is not lonely. That means he can accept support and treatment. And this means the responsibility for us as therapists that we have to provide a very differentiated and wide therapeutical concept. We can talk of medications, rehabilitation, psychotherapy, and different interventional treatments. There are some who even discuss the necessity of operations up to amputations in case of CRPS. Do we have any evidence? Well, a recent study showed merely low to moderate evidence for medication, physical therapy, and interventional therapies. Now, interventional therapies and operation always are a problem once we like to discuss evidence. Why is there a lack of high-class evidence? Well, there are two main problems. One is the problem of inclusion criteria versus the known diversity of patients. And the other is the problem of blinding within these studies and the impossibility of SAM procedure in the most interventional and operative procedures. Now, medication. There's a long list, and I will not discuss this in detail. You can think of applying radical scavengers. You can think of anti-inflammatory drugs. You can think of vasoactive drugs. You can think of botulinum toxin. You might administer an NMDRA antagonist. Even immunoglobulins are administered, and there also is a renaissance of thalidomide, what is not without some problems in the German-speaking part of the therapeutic society. Plus, all co-medications that we know of treating neuropathic pain might be of interest: antidepressants, pregabalin, and carbamazepine. Rehabilitation activities we heard of: physiotherapy and occupational therapy routinely are presented to the patient. Unfortunately, in many cases, you cannot do this because pain aggravates and the patients do not stick to the therapy. Mirror therapy is administered. Imaginary therapy, which means the patient thinks of moving an extremity but doesn't do it. And spatial therapy means the patient puts the sick hand into the space of the healthy hand. In psychotherapy, in former times, there were behavioral techniques. Nowadays, it has changed a little. We think of acceptance-driven therapy forms, and we use resource-orientated and mindfulness-based techniques, which, in other words, means meditation. Now, interventional therapy. In every patient where you suspect a CRPS, a infiltration to the sympathetic chain has to be done, because it has to be decided whether there is a sympathetic maintained pain in this case, or whether it's sympathetically independent. There is a fairly good evidence for this. It's 2B+ with in the discourse of Guyot means that it's highly recommendable. This is such an infiltration under fluoroscopy. In case there is a sympathetic maintained pain at the individual patient, you can think of radiofrequency at the sympathetic chain or neurolytic techniques. Neurostimulation, and I will come to this back later. Neurostimulation is a very upcoming treatment for CRPS. Conventional stimulation, which means low frequency stimulation, 50 to 100 hertz, has a fairly good evidence. It would look like this. Now there are upcoming therapies like the retrograde stimulation, where the electrode is pushed downward, and the dorsal root ganglion stimulation, which is something very exciting, just emerging, especially in Europe, because there is no approval for the US yet. If you administer conventional neurostimulation, we nowadays put in 2 leads, one more to the middle of the spine and one more laterally next to the dorsal root entry zone. This is a patient with a CRPS of the foot, and CRPS of the foot is very bad, has got a very bad outcome with conventional neurostimulation because it's hard to find a hot spot within the thoracolumbar spine. This is why now we tried to put the electrode retrograde next to the dorsal roots, to the spinal ganglion. And this is the very new technique where you put in an electrode just transforaminally. This is the foramen C6T1, where we try to find a spot for a CRPS of the hand. Very interesting in this case is that if you stimulate the dorsal root ganglion, very surprisingly, you get stimulation in different dermatomes. So this patient with the C8 electrode has stimulation within the whole hand, C6, C7, and C8. This is the patient I'm talking about. The patient, I saw this patient in this situation. 1 year ago, he was operated on the carpometacarpal joint D1 due to wrist arthritis. And when I saw him, he could just hold his hand like this, just a complete fist, with pain 1 out of a scale of 10. And if he just tried to open the fist just a little tiny bit like this, he had 10 out of 10. We put in this electrode, and after 2 weeks, we already re-implemented occupational therapy, which preoperatively could not be done due to exacerbation of pain. The patient now is able to open the wrist like this with a pain 1 out of 10. Okay, so just let me tell you how do I do it if a patient with CRPS shows up. Well, first of all, I try radical scavenging, and I trial transdermal application of nitrous oxide donators and dimethyl sulfoxide. So this is the very conservative approach. I very early think of antidepressant drugs. I myself prefer duloxetine, which is a selective noradrenaline and serotonin reuptake inhibitor. I prefer it in comparison to tricyclic antidepressants because especially the younger patients, they suffer from pretty much reduced libido. You always can consider pregabalin. Many patients do not like these medications due to the produced cognitive deficits. We work with the patients with mirror therapy and we perform lymphatic drainage. We think of resource-oriented psychotherapy, for instance, hypnosis, and we think of kind of meditation-oriented activities. We do a sympathetic block to decide whether it's a sympathetic maintained pain. Maybe we perform a radiofrequency, and we think it is very important to think of spinal cord stimulation in general, especially since there is pretty good data that this is a therapy being cost-effective. Once you think of that these patients, they will not, otherwise they will not go back to the working place. They will stay in hospital quite often and repetitive. One might consider a very early trial of spinal cord stimulation. There are preliminary data that show that if you put in a stimulation electrode, if there is a patient with a very young CRPS, couple of weeks. You put in an electrode on a not definitive base, which means the electrode just comes out of the skin, and you put a generator next to it, and you leave in the electrode for a couple of weeks. You will realize that in a few days, sometimes within 24 hours, the edema is totally gone, and physical therapy can be installed. Thank you very much.
Thank you. Can all the speakers please come up? Christian? Okay, before we have questions, I'll ask a quick question to Dr. Hartmann. Dr. Hartmann, the pain people in the States do use the stimulators. They'll do a trial first and then do a stimulator. But I noticed that they tend to do it after multiple blocks. So if a block works but doesn't stay working, at least the people in our area tend to do 5 to 10 blocks before they'll consider a stimulator. Do you have an opinion on that? Because I'm not. Sounds to me like you're recommending earlier stimulation.
Well, unfortunately, in the most cases, we see patients that have an CRPS for a couple of months or 5 years. So the question I put at the end most often is not the right question. But in case there is someone who developed a new CRPS, you definitely should think of this option.
Earlier,
yeah.
Thank you.
Plus, sympathetic blocks just help if there is a sympathetic maintained pain. If it's not, and in most dystonia patient and in most neuropathic patient, there is not a sympathetic maintained part of pain, so they will not help at all.
Thank you. Questions?
My question is that if we continue to believe about post-op arthrofibrosis of the knee in females with red color, hair red color, and the spots on the face. Yeah, because many years ago, they told about this in AOS, American Academy.
Well, there are many. I can say that in America, at least, there's a lot of rumors about redheads and people with freckles on their face, and they have more bleeding, they have more fibrosis. I'm not sure I've ever seen a study. Christian, do you know if that's the case? But I hear it the same as you've heard it.
Yeah, I don't think I can add a lot more to that. I do not, in my review, I did not find any evidence for that. I think there's certainly, some clinical pearls and wisdom that goes around to that effect, and I think that is often very much driven by personal experiences. I don't think you can put science to that. I think this is mostly, based upon personal experiences.
Questions?
Skutek in our group some many years ago has tried to correlate fibrosis to a HLA BC27 antigen like in Bacteref, and there was a weak correlation, so it's certainly worth to go on in this, but I think it's not with the morphotype, but there are some genetic factors. There's obvious, and there was a slight correlation with ALB27 like in Bacteref. But I wanted to ask something about the patella. You reflected that there might be patella infera or patella baja, but what do you do if you have that? It needs some treatment, obviously.
It's a very good question, and this is a very hard question to answer. What I think, and I did not touch that in the talk. There's, I think, a graduation. If you have a fully established patella baja with a full contraction of the infrapatellar tendon or the patella tendon that we call, I think in those cases you may have to work on the bony attachment because it's very hard to lengthen that tendon. There is techniques described out there. I personally have no experience with those techniques, and I'm worried about it. So in those cases, I will do a superiorization of the tubercle, and you can do that with a slightly wedged osteotomy. However, you have to be careful because you're somewhat limited in how much you can correct here. It's typically in the vicinity of about 5 to 7 millimeters. You can usually do that, and that may be all you need. I use the Cartan ratio to determine how much would be necessary here. In cases where the actual patella tendon is simply captured, I think it is really important to release the anterior fat pad and also to do an actual anterior recess release. I think Dick Stedman has talked a lot about that in the past, where you actually work with your arthroscope and your shavers underneath the joint surface in the front. You go past the intermeniscal ligament down into the recess and make sure that you free that up fairly nicely, because this is where you have most of your adhesions. And at the same time, you work into the lateral medial recess, and then you can often release that capture of the patella tendon. And I think those will be the two recommendations that I would have specifically for that problem.
Okay, if there's not, oh, sorry, there are questions. Good.
It's a question for you. Steroids. You mentioned using that as when you start to suspect problems with the joint or going stiff. That would be very useful if we have that confidence to do it.
Well,
what
actually,
do you think?
I think Christian mentioned it, but I use it too. I see, I have patients sometimes who come in, they look a little boggy, and they may have, if it's with an ACL, what I call a periostitis, and they're just, it bled along the front of the knee, and they're just getting that look like it may head. And if I put them on a Medrol dose pack, it's been clinically helpful, but I have it's just anecdotal evidence.
Yeah,
there's been a small report that is not Medline listed by a series of patients that Bernie Bach, treated that way, and I trained with him, and he introduced me to that idea. But I don't think there's any true formal studies on that. But I find it clinically helpful. It's something very commonly used in the U.S. as a Medrol dose pack. It's a relatively low dose, progressive 1-week course. Starting out with about 10 milligrams and then gradually going down per day, I'm not exactly sure what it does. It does decrease the inflammatory response overall, and often they also come back and say my back pain is gone too. It is great, but it does help these patients.
But if you look at the shoulder surgeons, they are very using that widely for frozen shoulder, and it is, I think, very well proven that. I mean, the mechanism of capsular contracture is not much different, so I think the effect in other joints like shoulder is more than clear, and you can refer to that literature. It's quite obvious that it works, yes.
It's also interesting, the Japanese literature has a large literature about hyaluronic acid to prevent capsular contracture and in the shoulder. So it would be interesting to see if those injections, would help here. But I've seen nothing in the knee literature. But like almost in the 80s, the Japanese were using HA for controlling shoulder fibrosis.
Just a question for Michael Hartmann. Thanks for the presentation. Is there any radiological diagnostic gold standard to demonstrate RSD, such as the thermogram, MRI scan, and what do you do about the inactivity osteoporosis in a weight-bearing joint?
Well, as far as I have an overview on the literature, I think there is no picture that helps you to give the diagnosis. So if you make an scintigram, well, maybe you see an increased turnover, but even this is not a definite criteria. If you make conventional radiographs, you see the osteoporosis due to inactivity, so this doesn't help you either. And MRIs, I found it very interesting to listen to the edema of the bone we heard in the last section. Well, with an CRPS patient, you wouldn't know not even just a little bit more. So I think it is a clinical diagnosis.
Okay. I want to thank everybody. Any more questions? Find us during the next break. But first, I think we'll call up Alex to get started on the next